We are talking about HCC, and the world over, HCC remains a disease of global public health significance for two reasons. For its high prevalence and for the very high mortality, which continues to remain on the increase, despite and in spite of the fact that the major risk factors are all preventable. Most of them are preventable. The prevalence remains on the increase. In 2012, 746,000 new cases were recorded. And in just 6 years, the number of new cases rose to over 841,000 the world over, accounting for 5% of all cancers in the world. It is the sixth most common cancer worldwide, 15th in males, and 9th in females. If we look at, this map is a bit blurred, but is the estimated age standardized incidence rates in males. This is the 2012, worldwide 2012, and we can, if you look at the Africa there, you can see what it looks like. The next one is the 2018 one, showing the age standardized incidence rates in both males and females. And again, Africa is shown there for what it is, but we'll ignore that. This shows the mortality rate. And if we look at the males in Africa, up here, you'll see that there are quite a number of countries in Africa that stand out quite there. The lower map is for females, not too important. Okay, now we come down to Africa. HCC is the fourth most common cancer on the continent. And bearing in mind the variations in the important risk factors, if we look at Africa, if we look at the map of Africa, you see it in two main ways, the sub-Saharan Africa and the North Africa. If you look at Egypt in red there, it's a bit different from the Maghreb countries of Libya, Algeria, Tunisia, and Mauritania, and Morocco. Egypt is different there because of that HCC is the leading cause of cancer in males in Egypt. The other countries in North Africa, that's the Libya, Algeria, Tunisia, Mauritania, and Morocco, are different because of the low prevalence of both the risk factors and HCC in them. But if you look at the sub-Saharan Africa, the whole of the sub-Saharan Africa, the prevalence is high, is the second leading cancer in men and third in women. Why is it not moving? Okay, then we look at, of 25 countries in the world with the highest rates of liver cancer, 12 African countries feature heavily: Egypt, the Gambia, Guinea, Ghana, Liberia, Burkina Faso, Senegal, Equatorial Guinea, Mozambique, Cape Verde, and Guinea-Bissau. I have a problem with this. Then why won't it go? Let me go back and then see. Go back. Okay, no. I want to do it myself. I have a problem with this.
This is bigger? Forwards?
Yeah, that's what I'm doing.
Backwards?
Yeah,
And control.
yeah, I know that. It is refusing to accept me. Okay. No. Let me use my hand.
Just a short click.
Okay, can you go back a little bit? Okay. So I'll have her help me in doing this. Can you just go back? What? Back. Okay. Then forward. Okay. Yeah, the world over, the incidence and mortality of HCC is higher in males, but more importantly, in Africa, it has been documented that the incidence is higher in males, especially in areas of high HBV endemicity. It's in the central sub-Saharan Africa, the age standardized incidence of HCC in males is 24.5, and the age standardized death rate is 29.5. While in the Western sub-Saharan Africa, the age standardized incidence in females is 10.9. Similarly, the age standardized death rate is 10.9. So the incidence is quite high. There is the difference in the male-female ratio. Has a number of reasons have been given to that. The natural protective influences of the estrogen against liver inflammation in women, and the higher exposure of males to carcinogens like tobacco, alcohol, and the higher prevalence of HBV in them are all giving us reasons for this. Now, the age at diagnosis is another very important item. The age at diagnosis, generally it's been agreed that the patients with HCC present at earlier ages in Africa when compared to other parts of the world. Well, a number of people have seemed to disagree with this, but there are many studies that have shown, that have really confirmed that this being the case. Young et al. Looked through a number of studies in many African countries, 11 or the sub-Saharan African countries, and Egypt. And it showed clearly that the median age at presentation in Egypt was 58 years of age, with the interquartile range of 53 to 63, while in the rest of Africa, so to say, the other 11 countries, the interquartile range was 36 to 58, with a median age of 46. So, and another group also showed that it is the same. A number of people have attacked this, and a study done in the US actually showed that the country of birth, being Africa in most of those cases, was more important than race or any other thing in determining the earlier age of onset. So this earlier age of onset, the people that argued against it were saying that it's because the age in Africa, most of the people that are being looked at are young. That is why the age of onset seems to be earlier, but this has been shown not to be true. It is really true that the patients present at an earlier age. Now, the risk factors, go back. Risk factors. In the difference between the
this is the pointer, but you have to show it on the screen.
Okay,
Yeah.
but this goes. The risk factors, the difference between the, very difference between the North Africa, you can even say Egypt and the rest of Africa, is based on the risk factors. But even at that, the risk factors, hepatitis B, C, aflatoxin, and iron overload seem to predominate in both areas. And alcohol and tobacco and the rest of the other things come in. Still the same thing. Still the same thing. And if we look at this, if you look at the rest of Africa, hepatitis B is the most important, and you look at the North Africa, Egypt, instead, hepatitis C is the most important risk factor. Now, other things are aflatoxin. This is a photograph of grains that are infected by the aspergillus flavors, and the next slide will show that it is really important in most of Africa. If you look at the upper part, okay, look here, you see that Africa, 40% here, this is the showing all over the world, but Africa shows how important it is that the aflatoxin, the exposure to aflatoxin, and look at all the countries shown here, aflatoxin exposure is also significant. Now, iron overload, especially if you look, the traditional beer that people drink, and where it is, this explains most of the rural dwellers who consume a lot of this alcohol have a deposition of iron in their livers. This is the alcohol consumption the world over. If you look at Africa, you see that Africa is well represented in that one. Okay, this is a summary of the study done by the African Consortium, showing that in the etiology of liver cancer in Egypt, you see that 84% of cases are due to HCV, while HBV is just 1%, and you look the rest of sub-Saharan Africa, hepatitis B is the most important, with 55% of the cases showing that. Now, the emerging risk factors, with the rapidly increasing urbanization in most of Africa, there's been an explosion or an epidemic of obesity, type 2 diabetes, non-alcoholic fatty liver disease, and the co-infection of hepatitis, HIV, HCV, HBV, and a combination of the aggressive HBV genotypes that are available in the continent with these are thought to be responsible for the earlier onset and more aggressive HCC phenotype that are seen. Now, the newer risk factor, that is the aristololic acid, which is the new kid in the block, that has been shown to be an important risk factor in other parts of the world, like Taiwan, Korea, Japan, because it's been identified in a subset of HCC there. It's kind of new. Well, it is known that the patients, so to say, are exposed to this due to consumption of herbal concoctions as drinks, as medicinals, and all that. And we know that that also happens in Africa. But we do not have any data, so to say, to tell us whether this is also important in Africa. but we know that herbal concoctions are freely consumed in most of Africa. So this is somewhere that we need to look to know whether we are spared of this or this is also part of what we should be contending with. Now, the disease burden. If we look at the estimated age-standardized incidence rates in 2018, for both sexes, we'll see that the burden in Africa is quite heavy. We follow then we look at the burden of the disease in Africa. Now, HCC is ranked first in incidence in countries like Gambia, Guinea, Mali. It is also ranked first in mortality in Egypt, Gibraltar, and Mozambique, and also in 24 other Central and West African sub-Saharan countries. It ranks first in mortality. In South Africa, for instance, it is 14 incidence and 17 mortality. These are all these. The incidence of HCC is said to have been underestimated in 34 countries. In 74 countries of the world, 34 of them are African countries where it is known that the incidence is underestimated. In 2012, as many as over 120,000 cases were estimated to have been missed. Sartorius and his group looked into this and showed that about 34 countries in Africa have gross underestimation of both incidence and mortality. And this is due to lack of data, poor reporting health records, lack of proper population cancer registries. Is either it's not there at all or it is not properly kept, so that it's about 20% generally of the world's data is missing in Africa. If we look at because of this, the incidence to mortality ratio is approaching unity, and it shows the heavy burden that we have in Africa. Economic burden. We've said it that the age at presentation in Africa, the people that are affected are the young people between the ages of 35 and 46. That's the workforce of the nation. So that the economic, it affects the economy of the countries all over, because the high cost of diagnostic tests were available, very high cost of drugs were available, lack of health insurance, and remember that majority of people pay out of pocket, so that it has a heavy toll on both the individual and the states. Now, if we look at this, the DALI in all these countries, you will see that the DALI in West Africa, West Sub-Saharan Africa, is very high. And what this is showing us, followed by North Africa, and then East Sub-Saharan Africa, what this is showing us is that the burden, this measures the burden of disease, and this is really very, very heavy on Africa. Now, the outcome. The outcome remains abysmal and has not changed in 5 decades. 95% of patients still die within 12 months. Young et al. Showed us that the overall median survival is 10.5 months in Egypt and 2.5 months in the rest of Africa. So it shows that the outcome is still very, very, very bad. This shows us the same study by Young et al. shows Egypt and shows the rest of Africa in blue. So, and if we compare this to the rest of the world, you can now see how bad it is for Africa. This is the survival here, and look at the rest of the world. Now, so incidence to mortality remains almost unity, and that shows that the situation is really serious. The mortality rate here, you look at the Africa, you can see how bad. This is estimated age standardized mortality rates in Africa, in both sexes, and it shows how bad it is. Now, I think this is the worst slide for me, because this is a WHO estimation of what we should expect in the next couple of years. Estimated number of deaths from 2080 to 2040. If we look at it, we can see that the increase continues. The red portion is what the increase by 2040. So it shows that nothing has changed and things will continue the way it is unless something is done. So in summary, we've seen the high prevalence, we've seen the major risk factors, the traditional risk factors still the same. We've seen the emerging risk factors that are adding to the traditional ones that make things worse. And we still see that the age of onset is much earlier in Africa, affecting the workforce and all that. Concerning the burden, the high incidence and mortality, despite obvious underestimation, tells us that things are bad, and heavy economic burden on the states and individuals. Outcome remains poor, incidence to mortality almost unity, no change at all in the over 5 decades, and projection into 2040 is abysmal. Thank you.